Welcome to Pediatric Case Review Respiratory Series. Today's lecture is a comprehensive case-based review of inhaled foreign body in children designed for general pediatricians. Foreign body aspiration is a true pediatric emergency, and it remains a leading cause of accidental death in children under 4 years of age. We will walk through carefully crafted clinical cases covering pathophysiology, the check valve mechanism, clinical presentation, examination findings, the classic triad, imaging strategies, anatomical distribution, red flags such as recurrent pneumonia, definitive management with rigid bronchoscopy, complications, organic versus inorganic foreign bodies, and prevention counseling. Timely recognition leads to evidence-based management and better outcomes for children. Let us begin. Case 1. A 2-year-old boy is brought to the emergency department after a sudden episode of coughing and gagging while eating peanuts. He is currently stable but has an intermittent dry cough. The parents wonder if they can simply take him home. What is the most appropriate next step in management? Option A. Reassure the parents. Option B. Administer nebulized epinephrine. Option C. Maintain high clinical suspicion for foreign body aspiration. Option D. Discharge with oral antibiotics. The correct answer is option C. Maintain high clinical suspicion for foreign body aspiration. The history of a sudden choking event while eating peanuts is called the penetration syndrome, and it occurs in more than 90% of confirmed cases. After the initial choking, many children enter a deceptive silent interval where symptoms temporarily subside as the foreign body settles distally and protective reflexes fatigue. This silent phase leads to dangerous diagnostic delays. Current clinical stability does not rule out aspiration. A witnessed choking event with high-risk food like peanuts mandates further evaluation, typically including imaging and a low threshold for bronchoscopy, regardless of how well the child looks at the moment. Case 2. An 18-month-old girl presents with a persistent wheeze that has not responded to bronchodilators. On examination, you note decreased breath sounds and localized wheezing on the right side only. The left lung field is clear. Which statement best interprets these findings? Option A. Unilateral findings strongly suggest a localized airway obstruction. Option B. Bilateral wheezing is required to diagnose foreign body aspiration. Option C. This is a classic presentation of viral bronchiolitis. Option D. Normal breath sounds rule out the presence of a foreign body. The correct answer is option A. Unilateral findings strongly suggest a localized airway obstruction. A symmetric chest examination is one of the most important clues for foreign body aspiration. The classic triad is sudden coughing, unilateral decreased breath sounds, and localized wheezing. This triad is present in around 65% of patients, so its absence does not exclude the diagnosis. A monophonic localized wheeze is highly suspicious for a fixed airway obstruction, in contrast to the diffuse polyphonic wheeze of asthma or bronchiolitis. Bronchiolitis typically presents with bilateral findings and a viral prodrome. Remember, even normal breath sounds do not rule out an aspirated foreign body, especially during the silent interval. Case 3. A child inhales a small piece of plastic toy. The object partially occludes a bronchus, allowing air to enter during inspiration but preventing it from leaving during expiration. What is the expected radiological result on the affected side? Option A. Total lung collapse, also called atelectasis. Option B. Pneumothorax on the contralateral side. Option C. Pulmonary edema. Option D. Obstructive emphysema, that is, hyperinflation. The correct answer is option D. Obstructive emphysema or hyperinflation. This is the classic check valve mechanism. During inspiration, the bronchus dilates and air flows past the foreign body into the distal lung. During expiration, the bronchus narrows around the object, trapping air distally. With each breath, more air accumulates, leading to progressive hyperinflation of the affected lung. There are 3 patterns of obstruction worth remembering. A bypass valve causes minimal obstruction with air flowing both ways and an audible wheeze. A check valve causes air trapping and obstructive emphysema. A stop valve causes complete obstruction with no air entry, leading to distal atelectasis and lung collapse. Understanding these patterns explains the variable radiological appearance. Case 4. You strongly suspect a non-radiopaque foreign body, such as a seed in a 3-year-old child. The initial upright chest radiograph appears normal. The parents are reassured, but you remain concerned. What is the next best imaging step? Option A. Repeat the same upright radiograph in 24 hours. Option B. Perform a barium swallow study. Option C. Obtain expiratory or lateral decubitus chest films. Option D. Order a high-resolution computed tomography scan of the head. The correct answer is option C. Obtain expiratory or lateral decubitus chest films. Most aspirated foreign bodies in children are radiolucent, including peanuts, seeds, and plastic pieces. Standard inspiratory radiographs are normal in up to 30% of confirmed cases. On expiratory films, look for air trapping. The affected lung remains hyperinflated while the normal lung deflates, making the obstructed side appear darker and larger. For young children who cannot cooperate with expiration, use lateral decubitus films. The dependent lung should normally collapse under gravity. Failure of the dependent lung to collapse indicates air trapping and a positive study. Barium swallow is not indicated, and a head-computed tomography has no role here. Case 5. A 4-year-old presents with acute onset of stridor, hoarseness, and a croupy cough. There is no fever and no viral prodrome. The history is suspicious for foreign body aspiration. Where is the most likely location of the foreign body? Option A, right mainstem bronchus. Option B, larynx or upper trachea. Option C, left lower lobe bronchus. Option D, esophagus. The correct answer is option B, larynx or upper trachea. Although the right mainstem bronchus is the most common overall location for inhaled foreign bodies, accounting for 80 to 90% of cases due to its more vertical orientation, this child's symptoms point higher up. Stridor, hoarseness, and a croupy cough localize obstruction to the larynx or upper trachea, which accounts for around 5 to 10% of cases. Laryngeal or tracheal foreign bodies are dangerous because they can cause acute, complete upper airway obstruction. Bronchial foreign bodies typically present with wheezing and decreased breath sounds rather than stridor. Esophageal foreign bodies can also cause respiratory symptoms through posterior tracheal compression, but the classic stridor pattern points to the larynx. Case 6. A 5-year-old is being treated for right lower lobe pneumonia for the 3rd time in 6 months. Each time, the symptoms partially resolve with antibiotics, but then return in the same anatomical location. The parents do not recall any choking event. What is the most appropriate next step? Option A, suspect a retained foreign body. Option B, diagnose cystic fibrosis immediately. Option C, continue repeating courses of antibiotics. Option D, assume underlying immunodeficiency. The correct answer is option A, suspect a retained foreign body. Recurrent or persistent pneumonia in the same anatomical lobe is a major red flag for an unrecognized foreign body, especially when the initial choking event was unwitnessed. Other red flags include treatment failure despite appropriate antibiotics, asthma that does not respond to standard bronchodilators, and localized lung damage such as atelectasis, air trapping, or early bronchiectasis. Cystic fibrosis presents with diffuse rather than localized disease and other systemic findings. Immunodeficiency typically causes recurrent infections at multiple sites. Continuing antibiotics without investigating the cause allows ongoing lung damage. The appropriate next step is bronchoscopy to both confirm and remove the foreign body. Case 7. A child has a foreign body highly suspected based on history of choking and unilateral wheezing on examination. The child is currently stable, oxygenating well, and in no acute distress. What is the gold standard management? Option A, chest physiotherapy and postural drainage. Option B, blind finger sweep to attempt removal. Option C, watchful waiting. Option D, rigid bronchoscopy